Good evening, everyone. How are you all? I'm good. Thank you, guys. Okay, so let's start our tonight's session. So these are your last two sessions with me, and these will be your left out topic sessions. So anything that we have left out, we will try our best to cover all of them today and also on Friday. Okay. So let's start with the CTG or cardiotocogram. So cardiotocogram, it comes in exams sometimes. It's a part of your obstetric preparation. So in obstetrics, sometimes they give you a scenario and then they give you a CTG and they ask you like what will be the next step and something like that. So you need to get a basic idea about CTG or cardiotocogram. So this is how a normal cardiotocogram will look like. And you don't need to go in too much detail about it, just a basic superficial idea. Many of you will not get it in the exam, but some of you might. Okay. So cardiotocography is kind of a like a ECG that we have done, but it's a different from ECG in a sense that it is mainly to check the uterine contraction and also to check the fetal heartbeat. So if you look over here, the bottom part is uterine contraction and this top part is fetal heart rate. And this uterine contraction in here, you can see that from here to here, there is 10 large square. So each large square is equal to 1 minute. So you need to find out that in 10 minutes, how many uterine contraction is happening. So in here, we can see that in 10 minutes from here to here, there is only 2 uterine contractions happening. You can also find out that what is the intensity of the contraction. In here is 40, 60. It's the intensity of the contraction. So you can see it is a 40 millimeter of mercury intensity contraction. Okay, so these are the two main idea that you can get from here. So what does it do, or why we normally look at the uterine contraction? It's just because your active labor sometimes will be defined as how many uterine contraction is happening, how long each of them are lasting, and how frequently they are coming. So that's also a criteria to think that patient is in a true labor, not in a false labor. Okay, so what is the normal labor uterine contraction? Do you guys remember from our obstetric class? Yeah, so true labor means that the contraction might not even last for 30 to 60 seconds. So contraction will last for 30 seconds or up to 60 seconds. And then the patient will, and the contraction will come every 5 minutes. Okay, so something like that, that will be the true labor. Now, uterine contraction will not be super important, but can anyone tell me what is the normal intensity of uterine contraction? Or if you want to know that if the uterine contraction is hypotonic, hypertonic, you need to know what is the normal uterine contraction. What is the normal uterine contraction in the active labor? No one? 40 to 50. Yeah. So 40 to 50 would be the usual in the contraction that we would be looking for. So that's right. Now moving on, what is the baseline fetal heart rate? So after we look at the uterine contraction and how many contraction is happening, so normally at least if the contraction is happening every 2 to 3 minutes, that's good. That means the labor is moving forward. And also we look at like how is the contraction intensity. The intensity, as the labor progresses, the intensity also get increased. Now, baseline fetal heart rate. So after uterine contraction, we look at the baseline fetal heart rate. And if you look over here, you can see 60, 80, 100. So this is the heart rate of the baby. The baseline fetal heart rate is basically, when you look at the CTG, where exactly most of the contraction is happening, or where exactly most of the fetal heart rate is. If you look over here, this is where most of the fetal heart rate is, right? So 120 will be the baseline fetal heart rate in this patient, okay? So the normal fetal heart rate is 110. So 110 to 160 is the normal fetal heart rate. If heart rate goes more than 160, that's fetal tachycardia. Less than 110, fetal bradycardia. Both of them are not good. Next is variability. So variability means that if you look over here, you can see that it's not just like in a single line. The fetal heart rate is coming up, like it's an ups and downs, right? So having these ups and downs are a good sign. It means that there is enough variability in the CTG. So normal variability is from 5 to 25 beat per minute. Now in your exam, you don't need to actually measure that. So it's not really important to measure the variability, how much variability it is. They don't ask something like that. It's just looking at it. So if you look on this CTG, definitely there is variation, and that is good. If you look on this one, you can see that there is no variation here. So the fetal heart rate is exactly in the same place. Now that is called reduced variability. Having a reduced variability is also not a good sign. Okay, so it means that the baby might be in distress. So when you look at the fetal part of the CTG, first thing you look at how is the heart rate of the baby. Is there enough variability in this CTG? The next thing you look at is accelerations. So accelerations and decelerations are important. So accelerations are normal. A normal CTG will have a little bit of accelerations time to time. So if we look over here, so accelerations are abrupt increase in the baseline fetal heart rate greater than 15 beat per minute and lasting for at least 15 seconds. So acceleration is sudden abrupt increase of fetal heart rate. Such as if you look over here, this one, this one, this one, these are abrupt increase of the fetal heart rate from the baseline. So baseline is 120. If it goes more than 15 beat per minute, so you can see this one is 150, right? So from 120, the heart rate jumped to 150. So that means 30. So that fulfills the criteria of greater than 15 beat per minute and lasting for at least 15 seconds. So this one in here, you can definitely say that this is more than 15 seconds because if one largest square is 1 minute, right? So this is definitely more than 15 seconds anyway. So the main thing that you look at, that if there is an abrupt increase of the fetal heart rate from the baseline, at least more than 15 beat per minute. Okay? So that's acceleration. Having acceleration is a good sign. It means that the baby is in a good environment. There is no fetal distress. whereas having decelerations are not a good sign. So there is no relationship of acceleration with uterine contraction, but there are relationship of uterine contraction with deceleration. So accelerations nothing to do with contraction, but mainly decelerations can have some kind of relation with uterine contraction. So deceleration is exactly the different. So it's the opposite. So in deceleration, there will be abrupt decrease in the heart rate greater than 15 beats per minute, lasting for at least 15 seconds. There are three types of deceleration: early, variable, and late deceleration. Early deceleration is physiological and it's normal, nothing to be worried about. So what is early deceleration? So early deceleration happens when there is uterine contraction happens, then it will definitely put more pressure on the fetal head. So fetal intracranial pressure will be increased, which will cause increased vagus nerve stimulation, and vagus nerve stimulation will cause a bit of heart rate drop or bradycardia, which is normal and physiological. So early deceleration, it will start when uterine contraction begins and recover when uterine contraction stops. If you look over here, so this is where uterine contraction started, and you can see that this is a deceleration and this is a deceleration, right? And this is where the deceleration also started. So when deceleration starts with uterine contraction and ends with uterine contraction, right? That's called early deceleration. Same in here. This is where the deceleration started, and this is where uterine contraction starts. This is where it ends, and this is where this also ends. So when the deceleration totally coincide with the contraction, that is what we call as early deceleration. Okay. Variable deceleration. Variable deceleration doesn't actually follow the contraction. It can happen with or without contraction. So if you look over here, this is where a deceleration is. This is where another deceleration, but it has no relationship with the contraction. So when contraction and deceleration doesn't have any relation, that's a variable deceleration. Now, variable deceleration is not a good sign, and it usually suggests cord compression. So if there is a variable deceleration, look at the cord, if the cord getting compressed or cord is getting prolapsed or not. Okay, so that's variable deceleration. And one of the most important thing not to forget is late deceleration. So late deceleration always pathological. It starts at the peak of the contraction and recover after contraction ends. So let's have a look. So this is the peak of uterine contraction. And at the peak of uterine contraction, late deceleration will start, right? Uterine contraction will be finished, but the deceleration will finish after that. Okay, same over here. You see the uterine contraction and the deceleration. So deceleration started at the peak of contraction, and then the deceleration is stopped after contraction has stopped. Okay, so that's what we would call as late deceleration. Does it make sense for everyone? Yeah, good. So late deceleration is pathognomic, and it suggests there is possibility of a fetal distress. And when you suspect fetal distress, the next thing you would do is to do a fetal scalp blood sampling for pH. So you'll take a blood sample from the fetal scalp and send it for pH. If the pH comes acidotic, it suggests fetal distress, and a need for emergency cesarean section is also will be the most important management in this case. So if there is a late deceleration, you would Your next step is a fetal scalp blood sampling for pH or lactic acid. If pH is acidotic or lactic acidosis is there, then that will require emergency cesarean section. So you can see another late deceleration over here as well. Okay, now that's mainly more or less all that you really need to know from CTG. So the basic things are, do you understand what is fetal bradycardia and fetal tachycardia? Do you understand what is variability? Do you understand how to check the uterine contraction? Do you understand what are acceleration and deceleration? If you understand them, you will be able to easily pick up any abnormality in the CTG. Okay? Any question from the CTG guys? So Chandima, if it goes above 50 and patient is on oxytocin, yes, you would reduce that. Variable deceleration means there is no relationship. So you can see that variable deceleration can happen without any relationship between the uterine contraction. And it suggests cord compression. Yes, we should go for fetal scalp blood sampling always when there is a late deceleration, most of the time. Because just because a late deceleration is there doesn't mean you will take the child to the emergency C-section. Okay, so you have to confirm it by doing the pH. Fetal scalp sampling in just late deceleration, not in other decelerations. If it is a variable one, you would check the fetal if the cord is getting prolapsed or compressed. Okay, so that finished our CTG now. Moving on to ABG. About the uterine contraction, Dr. Ume, we discussed about the normal uterine contraction in our obstetric class. So there is a obstetrics class, the labor class that we have discussed, and you can also go through the Kaplan step to CK for that. But ideally, every stage has different kind of intensity. So in the first stage of labor, contraction will be up to 50. Like the intensity will be up to 50. In the second stage, it can even go up to 100. At the same time, the frequency of contraction will be 3 to 5 per 10 minute in the initial stage. Okay, so normally if you think that up to 50 intensity in the first stage of labor and 3 to 5 contraction in 10 minutes in the first stage of labor. Okay, so you can remember in that way. You need to, so if there is it depends, because remember how we decided about like hypotonic, hypertonic. So if a patient is on oxytocin, and if you check the contraction in the first stage of labor, contraction intensity is 100. Definitely it is hypertonic. Then you need to stop the oxytocin. So yes, we check the intensity of the contraction. We check how frequently it is happening, because that's how we find out if it is a normal or abnormal labor. So CTG is just utilizing your labor knowledge to find out what is abnormal. Okay. Now, I can't discuss the full labor today because that has been discussed. So if there is any confusion, go back to the labor class, find out what is the abnormal finding in first stage, second stage of labor, come back to this CTG, and then try to connect together. That will make a lot of sense. Okay. Knee and ankle, I don't know if we would be able to do that. So Dr. Sana, that if we can't, then it will be a video recorded session that will be provided. Okay. So knee and ankle, it will take a lot of time, which is not the ideal. Most of the time, we just ask you to go through the recorded class. And it is not the most important topic to discuss in the left out topics. So the left out topics will be decided by me mainly, like what are very, very important that you shouldn't miss. And if after that, if there is anything left, then I will go with your idea. Okay, so let me finish what I want to finish, and then I will listen to what you guys want me to finish. Okay, because I know much better that what's coming in the exam and what is very important. Okay, moving on to ABG. Just give me a moment. Okay, now I'm going to give you a very good idea about arterial blood gas analysis, which a lot of candidates get it in the exam. This carries a high mark in the exam, and if you can get it right, definitely that will be a very, very positive thing for the exam. Okay. So first of all, for arterial blood gas analysis, they will definitely give you a scenario. So even by looking at the scenario, you will get an idea that what it can be. And then just if you have a basic knowledge on arterial blood gas analysis, it's not very difficult to come to a conclusion. So when we talk about arterial blood gas analysis, this formula is very important to understand. So pH equal to bicarbonate divided by partial pressure of carbon dioxide. So remember this formula because that's what's going to really help. So first of all, you need to also know that what are the normal finding for this thing, because normal usually are not given in the exam. So pH equal normal pH is 7.35 to 7.45. Partial pressure of carbon dioxide, normal is 35 to 45. And bicarbonate, 12 to 16. Some people go up to 18, but that's also fine. So these are what you need to remember, because if you don't remember this, then you would not even know what is normal and abnormal. Sorry, I don't know why it's just going like this. Okay. Now, once we know the normal value, first of all, always remember in a ratio, when this is numerator and this is denominator, in a ratio, when the numerator decreases, the full ratio decreases. In the same way, if numerator increases, the whole ratio also will increase. So normally, what we look at that which one is controlled by what? Bicarbonate is controlled by your kidney. Partial pressure of carbon dioxide is controlled by respiratory system. So when there is abnormal pH due to bicarbonate problem, that is what we call as metabolic problem. When there is abnormal pH due to partial pressure of carbon dioxide, then we call it a respiratory problem. Now, by the problem is either it is acidosis or it is alkalosis. Okay? So what is acidosis? Acidosis means if the pH gets below 7.35, that's acidosis. Alkalosis, if pH goes above 7.45. All right? Now, coming back to the ratio, you should also remember the other thing that in a ratio, if denominator decreases, the ratio will increase. Okay? Same, if denominator increases, the ratio will decrease. Now, this is a basic mathematical knowledge, and without that, this will not make a lot of sense. Okay? So, you need to know what is the normal pH formula. You need to understand bicarbonate problem gives us metabolic issues. PCO2 problem gives us respiratory issues. And it could be either acidosis or alkalosis. Okay? And remember the normal value of this. pH equal to, normal pH is between 7.35 to 7.45. PCO2 35 to 45. Easy to remember by this, right? Bicarbonate, 22 to 26. Okay? So that will be your main value that we need to remember. Now, if we look over here, that first of all, let me just give you one thing. So pH equal to bicarbonate PCO2. Let's say you have found that pH is low, and then you found bicarbonate is low and PCO2 is normal. Now we understand in here that because bicarbonate is low, so because numerator is low, pH is low, so this is definitely causing the problem. And if pH is low, it means it is acidosis. And if bicarbonate is the main culprit, then it is metabolic acidosis. Now there is no compensation here. That's why the PCO2 is normal. So the compensation part is the main complicated one in the exam. ABG or VBG, it's ABG. Yes, Dr. Mimona, sorry, it was 22 to 26. Reference range will not be given in the exam. Most of these will be, but ABG, I have seen that they don't. The denominator part is if denominator decreases, the ratio will increase. That means the vice versa. That's the ratio how it works in mathematics. Okay? Now, when your body goes through any kind of acid-base disturbance, your body will have its own mechanism to compensate that. So the problem is metabolic. So your body will try to compensate it by doing something in the respiratory system. Okay? So what it can do to increase the pH? What do you think, guys? So if your body wants to increase the pH, what it has to be done? So if your body wants to increase the pH, right, your body needs to lower down the PCO2, right? And that's the only way your body can compensate. That means if your body starts you to do hyperventilation, then you will lose more and more carbon dioxide. So carbon dioxide will come low, and your body might be able to bring back the pH to normal. And when your body do that, that's the time it becomes respiratory compensation. So if we give you another formula where bicarbonate is low, pH is low, and PCO2 is also low, what would you tell it? Now you might think that both is low. Why we are thinking that it is bicarbonate the culprit? Why it is metabolic? Why it is not respiratory acidosis? Because if it was respiratory acidosis, then because PCO2 is low, ideally the pH should be high, right? But pH is low in here. That means it is not the respiratory problem causing the acidosis. It is the bicarbonate which is causing the problem. Okay? So this is metabolic acidosis with your body trying to compensate. So it will be respiratory compensation. Okay? So the name of this acid-base disturbance is metabolic acidosis because bicarbonate is the culprit. And then your body is trying to compensate it by reducing the PCO2. So that's why it is respiratory compensation. Does it make sense, guys? Because if you understand this, you understand ABG. Okay, very good. So let's move on to the next one. Let's say this is the pH, that's bicarbonate. This is PCO2. pH is high. pH high means we already know it is alkalosis. Our question is it metabolic alkalosis or respiratory alkalosis? So we found that patient has got low PCO2 and let's say normal bicarbonate. Now this is easy because we already know that PCO2 is the culprit causing the high pH. So that means it is respiratory alkalosis. Now everyone gets this, but in exam, they don't like usually come this easy. So they usually give you the compensation one. So pH is high. PCO2 is still low, but we have also found that bicarbonate is also low. Now, what is the, what's causing the problem? What is the main problem? Is it PCO2 causing the high pH, or is it the bicarbonate causing the high pH? What do you think? If you remember the math, you will understand what I'm talking about. PCO2, right? Because if denominator decreases, then ratio increases. So it is the PCO2 that's the main problem. So we understand that it is respiratory alkalosis plus. So your body will try to compensate it. So pH is high, so your body needs to lower down the pH. So what bicarbonate needs to be done? So if bicarbonate, because it's numerator, if it decreases, pH will come down. So that's why bicarbonate is low here. So that is what will be respiratory alkalosis with metabolic compensation. Okay? Does it make sense? Anyone needs me to repeat this thing? I hope it is making sense because it cannot be any easier. Let's see what if bicarbonate is high. So pH, bicarbonate, PCO2. So pH high, bicarbonate high. So what do you think this patient is having? Now, if you look at here, if PCO2 was the culprit, because PCO2 has got increased, pH should not be increased if this was the culprit, right? Because if PCO2 is the main culprit, pH should be low. So it is not the main problem. The problem is bicarbonate is high. That's why pH is high. So it is metabolic alkalosis. And now you can easily understand. So respiratory compensation. Okay. So do you think like if anything comes in exam from acid base, will you be able to now diagnose it? Ideally, yes, I would definitely say that remember some of the important causes of these main things. So re, uh, if you go to Google, you should be easily able to find out some of the main causes. So you can read like what are the main causes of metabolic acidosis, main causes of alkalosis. So just get the common diseases. So five common diseases. If you remember, that will make it easier in the exam. It is the same. So ABG, VVG, the main acidosis, alkalosis things are same. It's like VBG means you're taking blood from the vein. ABG means you're taking blood from the artery. Any questions? Anything that you guys didn't understand? Okay, if we want to talk about compensation, let's go with another one. So let's say you have got a patient who is coming for like um, who is having acute shortness of breath. Okay, so you've done um, the ABG or VBG, and that is what you have got in the finding. So what do you think this patient has got? So if we see in this patient, pH is low, bicarbonate 15, so that's low, PCO2 50, that's high. Now, I just tricked you guys. This is, yes, this is right. This is not, because if you see here, the bicarbonate low, it can cause low pH. PCO2 high, that can also cause low pH. So this is what's called mixed acidosis. So when you get a compensation, the easiest way to remember is that your everything will be on the same direction. And that's the time you get compensation. So the easiest way to remember that when everything is on the same direction, low, 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 or high, 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 that's compensatory one. But when these are in opposite direction, that's mixed. Okay? Now, if it was like pH low, bicarbonate low, and PCO2 is also low, then you can think that, well, this is the bicarbonate is low, pH low. So we know that if the numerator decreases, the pH decreases. So that's most likely what's causing the problem. So it is a metabolic acidosis. And we can see here PCO2 is low. So low PCO2 is trying to increase the pH. So this is the respiratory compensation. Mixed means it has both respiratory and metabolic component in it. It doesn't come in exam that much. All I want you to understand is to know that when to think of mixed. But it's not very common. It is a complicated thing. It doesn't come often in the exam. Dr. Asfa, what do you mean by normal pH? Normal pH means it doesn't have any acid-base disturbance, right? All right, guys. Now, I would like you guys to have a look on Geekymedics. So if you open up your Google, just write Geekymedics ABG interpretation. So Geekymedics has a good discussion about ABG also. So if you want to go in a little bit more detail, there are some examples given in here, okay, about the compensation and everything, the mixed as well. And they have also given some of the common causes, which is important for you. So go through this guideline, and that will be more than enough for your ABG preparation, okay? And Dr. Ayam, so if we see here, that is the one that we discussed, right? So pH low, bicarbonate low, PCO2 is a bit high, right? So that's a mixed pattern. So could be maybe lactic acidosis hypercarbia, that might be the diagnosis. Okay, moving on to the next topic. Before we take a break, I would like to finish the imaging, because we finished imaging up to the chest, not the abdomen, right? All right, so I hope you guys remember the CT scan basics, because that will be important. So we finished up to the chest. Now we are moving on to abdominal CT scan. So abdomen has got a lot of structures, but not everything is important for your exam preparation. So if you look over here, so in a CT scan of the abdomen, it depends at which level you are taking the scan. So not everything will be visible in one slice. So in one slice, you might be able to see liver. Next slide, you might not be able to see liver. You might be able to see the kidney better. So it depends. If you look on this CT scan, it's mainly on the upper part of the abdomen. So on the right-hand side, the big one that you see is the liver. You can see the gallbladder over here. You can see the pancreas. And is this spleen or kidney? It is spleen, right? Because if it was kidney, then this side also there should be a kidney. So always compare, because comparison will really help you in the exam. So this is spleen. We can't see the kidney here because it's a little bit down. You can get the abdominal aorta. And then these are a little bit of intestine you can see. Okay, so that's mainly the important ones that you need to know. And if we go down a little bit, now you can see just a little bit of liver is visible, but now the kidney is more visible on the side. And in here, you can also visualize that lots of bowel loop. So the bowel loop, which is on the periphery, that's the large intestine. And that's what's in the center or in the middle, that will be a small intestine. Okay. In here, we can see a little bit better that what's large and small intestine. So on the periphery, that's the colon or large intestine. And in the middle, you can see the small intestine. Now that you know about the normal abdominal CT, let's go on to the abnormal CT. So in here, this is called hematoma. And you might have seen these kind of questions quite often, that they give you a patient who is on warfarin and coming to you with a bit of like abdominal pain in the middle of the tummy. And then you send the patient to the scan, and the scan shows a rectus sheath hematoma. So you compare, so you can see this is the rectus sheath, and this side on the right hand side, this is what we call as rectus sheath hematoma, which you would not get on the other side. Okay. You can also see this side has got the hematoma over there. So history is very important because you are not supposed to be a radiologist for this exam. And all you need to know the basic, always remember that, because they don't expect you to know how to get like a small pancreatic cancer in a CT scan, which even radiologists sometimes can't find out. So anything that is given in the exam, that is usually quite definitive. They will not give you something for like being a specialist. Okay. So these are all rectus sheath hematoma, as you can see. Okay. And that's also a rectus sheath hematoma, very commonly given. So make sure you understand if it is coming in your exam. Now coming to intestinal obstruction, super important for exam. It's also very hard to diagnose a intestinal obstruction just by looking at a CT, especially just one slice of CT. If you have multiple slices, which you have normally, then it's not very hard. But if they give you only one slide, it is difficult. But I want you to be smart in the exam and understand how easily you can find out what is a small bowel obstruction and what is large bowel obstruction. Now, definitely the symptom is important. You remember that a small bowel obstruction will come with, like initially there will be pain and vomiting, followed by constipation and abdominal distension. Whereas large bowel obstruction will have constipation and distension first, and at the end, pain and vomiting. So these symptoms will be given in the question, and that will first give you a hint that what could be the diagnosis. So now that, let's say you have got a patient with features of a small bowel obstruction, then they want you to look at a CT scan of the abdomen and to confirm the diagnosis. So then what you see is, in a normal CT, the loop of bowel are not separate like this. In here, you can see the loop of bowel are all kind of like a small ball shaped, right? And that is what you get in adhesional intestinal obstruction, which is mainly a small bowel obstruction. Okay. Same in here. You can see in this CT scan, the small bowel is kind of like rounded loop, no more a continuous loop of bowel. So this kind of finding we would get in a small bowel obstruction. Okay. Now, small bowel obstruction is easy because we know that what to look for. But diagnosing a large bowel obstruction in a CAT scan or CT scan is one of the hardest one. Because 75% cases, the large bowel obstruction happens due to a cancer. And you can't usually see a cancer which is in the lumen just by doing a CT scan. If it is not too big, it is not very commonly found in a CT scan because you need to do a colonoscopy to diagnose this. So it is hard. So in this case, you need to be a little bit smart. The thing you need to see that if there is a features of large bowel obstruction and you can't see any of the small bowel obstruction additional features like this, you know that this is large bowel obstruction they're talking about. And you know that 70% cases it is a cancer. So if you can't find out the cancer, then just click sigmoid cancer or colon cancer as your diagnosis. Okay? Because in here, there is cancer. So this is where the cancer is basically, but as I see that I am also not a radiologist, it is also difficult for me to even understand it is a cancer. So for someone who doesn't have that kind of a specialist knowledge on a radiology, it is going to be very difficult to find out. Even sometimes radiologists will miss this. Okay? So they don't expect you to also diagnose this in the exam. But the thing is that being smart is important in exam. So if they have given you features of large bowel obstruction, and then also if you see on the CT scan, there is no features of a small bowel obstruction, then definitely it is large bowel. And we know that 70% cases, it is cancer. What is the other common cause? Sigmoid or cecal volvulus. They don't give a CT of volvulus because volvulus is very easily diagnosed in an X-ray. Okay, so it is also unusual to give you a CT scan of sigmoid volvulus because usually X-ray is more than enough to diagnose that. Okay, so think in that way in the exam, it will be easier. But if you look on this one, if this patient has features of large bowel obstruction, you can easily understand that there is definitely a block here. After that, you can't see anything. So that's cecal cancer. Okay. But again, if you're not sure, you can easily come to a conclusion just by the things that I have mentioned. Sometimes, along with the CT scan, if you have done a X-ray, you know how to diagnose small and large bowel obstruction. We discussed that in the class. If you get a colon cutoff sign, that's also one of the very important finding to think of a obstruction by a cancer. So you can see here that's a transverse colon. After this transverse colon, there is no gas shadow. So that means there must be some kind of obstructing lesion here. That's why the gas is not passing after that. So this is also a possibility that it could be a cancer, especially a sigmoid or descending colon cancer. Okay. Same in here, you can see the cutoff sign, and this patient also having features of large bowel obstruction. So how we know? Because you can see the haustral folds, see here. So these are large bowel obstruction, possibly due to a mechanical obstruction, and possibly it is a cancer. So that's mainly large and small bowel obstruction. In our class, we discussed about how to differentiate sigmoid volvulus and cecal volvulus. We discussed about the treatment of it in GIT, so we would not go through that again. And also we discussed a small and large bowel obstruction X-ray, okay? The cecal cancer usually will look like this. So that's also easy to remember. So cecum is on the right side. So cecal, if it is a cecal cancer, it will look, there will be something abnormal on the right side. Okay. And what is the commonest cancer? Sigmoid is the commonest one. Moving on to CA pancreas. CA pancreas, again, it is difficult. So if they are giving you a CT scan of CA pancreas, they would give you something which is easily visible. So it will be like this. So if you look over here, so you can easily find out from here that where is the problem. Okay. So you can see here that it's the liver. Okay. And then you can see over here, that's the pancreas. And what you see here is a kind of a irregular shaped mass. And if you see that, then that's a very definitive possibility that it is a head of the pancreas cancer. So normally, if they're going to give you a pancreatic cancer, it should be something really, really visible and definitive like this. Okay? Then there is diverticulosis and diverticulitis. So sigmoid diverticulosis, sigmoid diverticulitis is important. And I hope you remember how diverticulosis patient presents. So diverticulosis patient will mainly have long-term constipation. They can have left iliac fossa pain, but they would not have any kind of fever, vomiting, no systemic signs. When there is systemic sign, it becomes diverticulitis. So again, it is difficult to differentiate diverticulosis and colitis by a CT. Radiologists are the one who can differentiate. But for you in the exam, look for those signs. If there is a systemic sign there, then it is definitely diverticulitis. How we know if there is diverticulosis at least? So if you look over here, that's the colon. And these finger-like projections that we see here, that's diverticuli. Okay, so that's how we know that it is most likely diverticulosis. Sometimes they might give you gallstone in the exam. Most of the time, gallstone is easily visible just by an ultrasound. But if they have done a CT and they found a gallstone, it will look like this. See, this is the gallbladder, and that's a stone in the gallbladder. Okay. Hydatid cyst. Hydatid cyst is not very common, but if it comes in exam, it's easy to diagnose. So if you look over here, hydatid cyst can happen in the liver mainly, but sometimes also in the lungs. So in hydatid cyst, there will be multiple daughter cysts in between a large cyst. So if this is a cyst, these are all multiple daughter cysts inside a large cyst. Okay, so that's hydatid cyst. But the best way to diagnose a hydatid cyst is like, let's see if we have got the picture. Nope. There was a good picture to show you. Let me see if I can show you from the Google. If you look over here, that's the lung. Okay, now this is a very good example. So if you see here, this is a large cyst, right? And in between the large cysts, there is lots of septations or division, and these are all daughter cysts in between. So if you get a large cyst and there you get a lot of septations like this, then you can think of hydatid cyst. Not very commonly asked in the exam anyway. Before we go to hepatocellular cancer, let's first know what is simple hepatic cyst, because that also comes in exam. Sometimes they give you a patient having a bit of abdominal discomfort or maybe totally asymptomatic, and they would ask you, they will give you the CT scan and they ask you what is the diagnosis. Simple hepatic cyst looks simple also. So if you look over here, there is a definitive border. There is no septations. It doesn't look bad, right? So simple hepatic cyst will be exactly like this. It's kind of a cystic structure, but it is regular, border is also regular, and it is smooth. So that's how a simple cyst will look like. Okay, nothing needs to be done. You can just wait and watch. But let's see how a hepatocellular carcinoma will look like. If you look over here, this is the liver, and just by looking at it, you know that there is something wrong. How? Because you can see here, this is a irregular mass, and there's a lot of things going on in here. Something like that is never a good thing. So hepatocellular cancer will be like this. You can see a small one over there. So in these patients, when you get a irregular mass or a lump on the liver, then you can think of hepatocellular cancer. Okay. Like if you look over here, you can see that definitely something is going on there. And all over, you can see something is going on. So the main thing is to look at if it is a irregular mass. And same in here, you can definitely find out that this doesn't look simple. There is irregular mass over this area. So when you get an irregular mass, most likely it could be a hepatocellular cancer. What is this? This is what we call as metastatic hepatic carcinoma. Whereas if it is a primary hepatocellular cancer, you might just get one irregular mass. If it is multiple one, like this, then you would think of likelihood of a hepatocellular carcinoma, but it is a metastatic liver carcinoma. What is the commonest site of primary tumor of metastatic liver cancer, guys? Colon cancer. Yes, colon cancer is one of the most common. Yeah, and then breast, lung, that's right. So colon cancer is the most likely. So if you have got a picture like this, your next step would be to get an endoscopy and colonoscopy, mainly colonoscopy to find out the primary tumor. And also you need to have a biopsy of the liver to know the exact diagnosis. Okay. So this is simple cyst as we discussed. Simple cyst again. Now there is a condition called polycystic kidney disease. Polycystic liver disease doesn't come in exam, but polycystic kidney disease can come. Oh, this was the one I was actually going to show you. So that's that hydatid cyst. You can see a mother cyst with lots of daughter cyst. Okay. So polycystic liver disease is not important for exam, so we would bypass that. Renal cell cancer. Renal cell cancer is important. So it's easy to differentiate because if you look over here, you can see that this is the right kidney. So where is the left kidney? So that's the left kidney. Okay. So this is what you can find out in a hepatocellular carcinoma. Same on this side, definitely the right kidney is still not visible because it's mainly liver side, but left kidney, because it's a large cancer, even you can see it now. This is the commonest one that you can see. So you can see the right kidney, the left kidney, that's how the big is the cancer. Okay. If you look over this is the polycystic kidney disease. So polycystic kidney disease, easy to understand. So on the kidney, you will see multiple cysts. Most of the time, it will be bilateral. So when you see bilateral cystic lesions on the kidney, that's polycystic kidney disease. Many times, patient who gets polycystic kidney disease, they can also get polycystic liver disease. Okay. So that's also PCKD. Hiatal hernia. Hiatal hernia, not super important, but if they give you a barium swallow, the hernia will look like this. So you remember what is a hiatus hernia, where the part of the stomach goes into the chest. Okay, so that's called hiatus hernia if you do a barium swallow or barium meal. And sometimes hiatus hernia, if you do a X-ray chest, you can get this air fluid level. So this air fluid level along the heart shadow, it's a very important finding to think of hiatus hernia. Okay, moving on to CT scan of the brain. When we discussed the neurology, we discussed a little bit about the subdural hematoma. We discussed about epidural hematoma. So those are very important CT for the brain. But apart from that, we also sometimes need you to understand how to diagnose ischemic stroke, how to diagnose hemorrhagic stroke, and just a basic idea about like metastatic melanoma, basic idea about sometimes also they ask you the brain tumor. Okay, it is very difficult to differentiate metastasis with just a brain tumor, but the main thing is always the history. So if a patient is a known melanoma patient, then that patient definitely has a high risk of metastasis, right? So in a metastatic melanoma, look for multiple metastatic nodule, because if you get that, you can be confident. But sometimes you can get only one. So in metastatic melanoma, especially any metastasis in the brain, most of the time you will get this kind of shadow. So whitish on the surrounding and then blackish or grayish pattern in the middle. Same in here. So you have got multiple. When you get multiple, you can easily think of metastasis as the likelihood of possibility. Okay. Now, if you look on this one, this is where a lot of people get confused in the exam. This can be brain tumor. This can be a metastasis. There is no specific way to differentiate between these two. So it's all about like getting a biopsy to know exactly what it is. So they don't usually confuse you with these kind of things, but if it does, the symptoms of the patient will lead you to come to a diagnosis. If the patient has got if the patient has got history of melanoma, then we would go for metastatic melanoma as the likelihood of possibility. Okay, but no history of melanoma, but patient having features of brain tumor like headache in the morning, early morning nausea, vomiting, ataxia or imbalance, then yes, we could think of brain tumor. Okay, but mainly you can see the irregular shape, and on the surrounding you can see there's a bit of edema, and that's causing the black part, and then in the middle there is white. So this black and white, you don't get it anywhere else except except the tumor, either metastasis or a primary one. Because you can get this kind of whitish thing in a hemorrhagic stroke, such as this. So hemorrhagic stroke means there is blood in the intracranial region. So if you see here, that's what we would get in an intracerebral or intracranial hemorrhage or hemorrhagic stroke patient. So white means like blood looks white in a CT scan, right? So when you get something like that and the history suggests hemorrhagic stroke, like sudden onset of hemiplegia, headache, vomiting, unconsciousness, or confusion, then we would think of hemorrhagic stroke. So how we get ischemic stroke? Because of ischemia, there will be necrosis, and necrosed tissue will look more black in comparison to the surrounding brain. So you can easily see here. So that's the part where patient has got ischemic stroke. Okay, so ischemic stroke will look black, hemorrhagic stroke will look white on a CT. All right, guys, so that's pretty much most of the CT that you would need for your exam. Any question? Okay, now hepatic hemangioma is difficult to diagnose just by a CT. So because hemangioma means there has to be some blood in that lump or mass, so they usually ask you to do an ultrasound to confirm it. So that will not be needed for the exam. This file is available in the portal. That's right, Dr. Mitra. Liver adenoma, not important. Stroke will be discussed. There is no specific difference between primary and metastatic. You need to have a biopsy to confirm it, but mainly primary will always be a single one. Metastatic will be multiple. But again, metastatic can be just a single one as well. The polycystic, so cyst will look kind of a more blackish, very black. And history is also important, Ahmad. So most of the patient who has polycystic liver disease, they have polycystic kidney disease also. And there is usually some family history as well. Okay. Whereas metastatic liver, it looks more kind of like a grayish pattern. Sometimes goes very closely with the liver, the liver structure. So it's not that black like a cystic lesion that we see in polycystic or polycystic liver or kidney disease. And always, definitely the history guides us. They never give us just a CT scan of an unknown patient. The history will always guide us to think of what could be the likelihood of possibility. Okay, let me take a 5-minute break. As for, yes, pseudocyst is important. I will discuss that after the break. Okay. All right. Thank you, guys. All right, everyone, let's start again. So we are almost at the finishing of the CT, right? So before we finish, I just want to show you the pancreatic pseudocyst. So pancreatic pseudocyst is a complication of pancreatitis. Can be a complication of acute pancreatitis or chronic pancreatitis. So it's usually a very big cyst in the middle of the scan. So if you see that this is the liver and these are some of the loop of bowel, that's the kidneys. In the middle, that's how a pseudocyst will look like. Okay. So like this. So when you get a pseudocyst, most of the time there will be a history that patient had a acute pancreatitis a couple of weeks ago. Now patient having persistent pain, nausea, abdominal tenderness, and then you do a scan and you found that there is a pseudocyst forming. So what is the usual treatment for pseudocyst? So ideally you wait for 6 weeks for the pseudocyst to resolve, because most of the time pseudocyst will not cause any problem. It will be totally asymptomatic. So normally we say if after 6 weeks, still patient is symptomatic, still the size of the cyst is more than 6 centimeter, then that will need a drainage. So there you can do a endoscopic drainage, percutaneous drainage, any of this is fine, but ideally you should wait for 6 weeks. But if it is a severe pain, patient having features of peritonitis, then definitely you would not wait. You need to go for urgent operation. But in other way, 6 weeks of conservative treatment, analgesics, anti-emetic, low-fat diet, that will be the treatment. Okay. There is a good discussion about pancreatic pseudocyst in, let me show you. So if you go to the NIH, this pancreatic pseudocyst, they have given a very good discussion about pancreatic pseudocyst. So I'll just copy paste this in your chat box so you can give it a read. Okay. And Dr. Ulme, about that recurrent nephrotic syndrome unresponsive to steroid, having hypertension, hematuria, that's focal segmental glomerulosclerosis, FSGS. That's usually the condition which presents as nephrotic syndrome, but eventually like they presents like a nephritic syndrome, and it will not respond to a steroid. Dr. Fatima, can you send these queries about which PDF is missing just in my inbox? I will have a look later on. Endoscopic is best. So if you look over here, so they have given option of both percutaneous and endoscopic, but endoscopic is the preferred because it is less invasive. Okay, moving on to prostate related questions. So if you open your John Murtak and if you go to the men's health chapter, I want you guys to give it a read of these chapters. Not super important, but main one is these disorders of the prostate that you can give it a read, but we'll discuss the main important ones. Read about prostatitis by yourself, but main thing that I want to discuss is prostate cancer. About the LUTS, so some of the patient can have just a benign prostatic enlargement, and those patients has features of LUTS. So some of them are obstructive symptoms, some are irritative symptoms. So those patients can have hesitancy of urination. That means They feel like they need to urinate, but nothing comes out. There is weak urinary stream, constant dribbling, sensation that their bladder is never emptying, and some of the irritative symptoms like urgency, frequency, nocturia. These are usual features of benign prostatic hyperplasia or BPH. Okay. Now, many patients who has benign prostatic enlargement, they can present you with acute bladder obstruction or features of acute urinary retention. So one of the most important thing that we should check if a patient comes with acute urinary retention is that if they have a very severely enlarged prostate. Okay. So we talked about this prostate thing maybe some times ago about the nocturia, about the oliguria. But coming back, if a patient has got urinary retention, the first thing that we do is that we can confirm by doing a bedside ultrasound. If bedside ultrasound shows that patient is having acute retention of urine, you need to insert a catheter to relieve the obstruction. And then when the urine comes out, you need to take that urine and send it for microscopy and culture to rule out any urinary infection. Okay, that's the first step of your management. After that, because it could be that patient having kidney problem or prostate problem. So you should also consider doing a PSA, which is prostate specific antigen. And you do the PSA to see if it is really high, because high PSA can be an indication of benign prostatic enlargement or can be a prostate cancer also. So a step-by-step approach is ultrasound, then if it is retention, catheterization, send the urine, do the PSA. There is a lot of confusion about can we do PSA after catheterization? Yes. Previously, people used to think that if you do PSA after catheterization, it will be high. That's a myth now. So you can definitely send the patient for a PSA just after having a catheterization. Okay. Treatment. So many patients who has prostatic enlargement, you can just do wait and watch if the symptoms are not too bad. If a patient coming with bladder outlet obstruction, that means they are getting a lot of symptoms, they're even retaining a lot of urine because prostate is enlarged, they can be helped with some medical management. So you can try a alpha blockers such as tamsulosin or prazosin, which will inhibit the contraction of smooth muscle of the prostate and make the muscle of the prostate relaxed. If it is relaxed, then it will no longer press the urethra. So that's your initial treatment. If this alpha blocker doesn't work, then you can add alpha blocker with 5-alpha reductase inhibitors such as finasteride or dutasteride. This usually reduces the testosterone. And because prostate needs testosterone to get enlarged, so if you can reduce testosterone, prostate can start to get shrink. The problem with this that this can reduce testosterone, so patient can end up getting decreased libido and ejaculatory dysfunction. But the best management is combination of these two, alpha blocker and 5-alpha reductase inhibitors. Now, if it is really bad, like patient coming to you with an acute urinary retention, then for those patients, you can even do a surgery, which is transurethral resection of prostate, TURP. These are the absolute indication of prostatectomy. You can go through that. The problem with TURP is that it can cause incontinence, stricture, and decline in sexual health, and retrograde ejaculation is quite normal. So these are the main issue why a lot of people doesn't want their prostate to be removed. But many of these will get better eventually. So incontinence, retrograde ejaculation, and erectile dysfunction could be the main problem. Very, very important topic for exam is prostate cancer. Ultrasound before catheter? Yes, if there is an option. If there is no option of doing an ultrasound, then just go for the catheterization. Prostate cancer is one of the commonest malignancy in men, and it is one of the common cause of death in Australia. Prostate usually get enlarged in elderly patient. It is rare that a patient below 50 will get a prostate cancer. By the age of 80, 80% of the patient will have a cancer. Okay, so it is that much common. So many times prostate cancer doesn't kill a patient because it is one of the slow growing tumor that someone can have. Family history is a risk factor, especially if there is a father or brother who has been diagnosed before the age of 65. Okay, now the main thing to remember that there is no need of screening of anyone with repeat PSA, even if their first degree had a cancer. It's not mandatory like bowel cancer or breast cancer. Someone who doesn't have any risk factor, there is no indication of doing a PSA. But someone who has risk, like father or brother was diagnosed before 65, for them, if they want to do regular screening, then yes, you can do a regular screening with PSA for them. Okay, so that's usually one of the other thing that many times gets confusing in the exam, that do we really need to do screening or not? So this is about the screening guideline. RACGP says that screening for prostate cancer is not recommended unless someone is specifically asked for it and patient has been talked about the pros and cons. Men at average risk of prostate cancer who wants regular testing should be offered PSA testing every 2 yearly from 50 to 69. Men with a family history who decide to be tested should be offered PSA testing every 2 yearly from the age 40 to 69. DRE is not recommended in asymptomatic men as a routine addition to PSA. Okay, so this comes in exam. Remember one thing, that it is only time we would do this if a patient wants to do it. So for someone who doesn't have risk, they can also ask for it, but for them, we would do it every 2 yearly from 50 to 69. Someone who has a risk, if they ask for it, then you can do it every 2 yearly from 40 to 69. Okay? Now coming to some of the other thing about prostate cancer. So prostate cancer, many times it doesn't come with any symptoms. Some can present with rapidly progressive lower urinary tract symptom. So they can come to you with lots of LUTS symptoms. Sometimes they would come to you with back pain, bone pain, hematuria, weight loss. So some of the cancer features can be there. But many times it is just diagnosed by doing a regular PSA. So when you do those screening, you end up getting a high PSA in this patient. When you suspect that it could be a cancer, like a prostate cancer is a possibility, in such case, then the next step of doing like, let's say you have got a patient who wants to do a prostate cancer screening because the father was diagnosed at the age of 60. So now you started doing it every 2 yearly. At the 3rd year, you found that patient PSA is gradually increasing every year. Then you would think that why it is increasing and how much it is increasing, that also matters. So let's have a look. There is an age-specific PSA range. For 40 to 49, that's the normal value. For someone 70 to 80, that's the normal value. So as the age goes, the normal value also changes. Now, prostate is a complicated thing if you don't understand what you are doing. So normally what we say that if you have got a patient who has PSA, let's say 60-year-old having PSA of 2. 2 years later, you have done another PSA, and that has now came up to 4. So it doubled. Okay, when now normally just one or a single PSA doesn't give us any idea. It's always about doing a repeat PSA to find out if it is getting increasing or not. We say that if 2 repeat PSA goes more than 0.7, so if from one PSA to the another PSA, if it is more than 0.7, that's a risk that it could be a prostate cancer. Anyone whose PSA is more than 10, that is always a high risk, and that is most likely a cancer, even a single one. Okay, so for this group of patients, when you have done it as a repeat PSA, and you think that, well, it could be a cancer, the next step will be to do a DRE. When you do the DRE, if you get hard lump, asymmetry, induration, loss of median sulcus, that will give you the next idea that, well, it could be a prostate cancer. After you have got that lump, the next step is to do a MRI of the prostate. Now, a lot of things are not written in here. I'm saying what we normally follow in Australia. So, because the John Murtagh and Australian guidelines are not very well written. So, this is what we follow. Okay. So, once you have done the MRI prostate will give us the idea that if there is any suspicious nodule growing in the prostate. If that says that, yes, there is a suspicious nodule, the next step is to go for a transrectal ultrasound guided biopsy. So you go for a biopsy from the prostate. And then the biopsy will be able to confirm the diagnosis. Biopsy also will be able to say what is the Gleason score. So Gleason score, it depends on the biopsy, that how aggressive is the cancer. Gleason score is scored from 1 to 10. 2 to 4 is low aggressive, 5 to 6 moderately aggressive, 7 intermediate, 8 to 10 highly aggressive. So this Gleason score gives us the aggressiveness. That means how fast this cancer can grow. And based on that, the specialist will decide that what will be the best management for this patient. Okay? Is it still fine with everyone? Are you guys understanding me? Now, based on all of this, the urologist will also be able to say the staging of the cancer. So T1 and T2 is the local prostate gland disease, and T3, T4 means that it has a spread beyond the prostatic capsule. Depending on all of this, the treatment will be decided. So there are a couple of treatment options. One, active surveillance, radical prostatectomy, radiotherapy, and then there is hormone therapy. So there are the 4 treatment options that we have got. Okay, so first active surveillance, then we can do radical prostatectomy, radiotherapy, and hormone therapy. So active surveillance is used mainly in patient with a low life expectancy. That means someone who is very elderly, has less than 10 years life expectancy. So in Australia, the average life expectancy is between 82 to 84. someone who is more than 75-year-old, they have less than 10-year life expectancy. For them, usually active surveillance is better because very rarely they will die out of cancer. Okay. So life expectancy plays a role, or someone who doesn't want to go for surgery or radiotherapy, you can just do a active surveillance with regular PSA monitoring. So that's number one option. Number two is radical prostatectomy. This is better for young patient who has long life expectancy above 10. So less than 75-year-old patient, no surgical risk factor, and the cancer is low, like low PSA. The cancer is not also like highly aggressive ones. So for this group of patient, radical prostatectomy by removing the whole prostate is the best approach. The risk with prostatectomy is incontinence and impotence, but it gets better. So who gets radiotherapy? Radiotherapy is also it's an alternative to prostatectomy. So someone who has long life expectancy, low volume PSA, moderately or worse differentiated tumor. Now you can understand that who has low volume stays and low PSA, they usually get better with prostatectomy. But someone who has got a little bit worse tumor, like T3, T4, for those patients, radiotherapy will be better option. The adverse effect from radiation is fecal urgency and diarrhea and impotence. Okay? So you understand when we do the prostatectomy, radiotherapy, remember that if the question says that it's not localized anymore, 60-year-old having a prostate cancer, the staging says that the cancer has invaded beyond the prostatic capsule. Maybe it's also in the lymph nodes and also the seminal vesicles. That's the time radiotherapy will be a good option to choose. But if it's a localized prostate cancer, good life expectancy, prostatectomy will be better option. What if the cancer has metastasized to the bone? So for metastatic cancer, androgen deprivation is the main treatment. So the option would be removing the both testes, which is no longer done anymore. But the common one nowadays that we do is this one. LHRH agonist. So luteinizing hormone agonist is the common treatment at the moment. So that can be done. Anti-androgenic tablet can be given. So this will be the treatment of choice for someone who has got metastasis. Okay, so that's basically the treatment of prostate cancer. Does it make sense, guys? Should PSA be tested before DRE? As I said, DRE is not complementary with PSA. So if back-to-back PSA is high, then you do a DRE. Yes, both radical prostatectomy and radiotherapy can be used sometimes if it's really needed. But it's normally, I have seen that it is either prostatectomy or radiation. That's usually the treatment. Let's do a few cases or questions. It will make a lot of sense. So 48-year-old man came to you worried about prostate cancer as his friend recently diagnosed with prostate cancer. He has no urinary symptoms, no family history of cancer. He is otherwise well. What is the best advice? So he's an average risk patient. Will you do a screening for this? No. He doesn't even fulfill the criteria. He's not even 50. So you'll say that you don't need a screening based on the symptoms and history. Okay? Patient with severe low back pain for 2 weeks. The pain has started gradually for a long time. He noticed weight loss. DRE shows irregular prostate with palpable median sulcus. Now, when there is irregular prostate, they are already mentioning that it could be a cancer, right? Having a back pain, maybe even a metastatic cancer. But your first thing to know is like, what is the PSA of this patient? Because that's the next investigation, right? You would not jump to MRI or CT directly, or you would not jump to a biopsy without doing a PSA first. So the first thing is PSA in this case, okay? And don't think that just because you did a DRE, you can't do PSA. You can. Those things are not true anymore, okay? So we will go for PSA in this patient. Man with urinary retention, mass 2 finger above the pubic symphysis. DRE shows enlarged prostate with smooth median sulcus, and you inserted the catheter. What is the most appropriate next step? Now, they have already said that there is urinary retention. What is the mass above pubic symphysis? It's a bladder, right? So urinary retention due to enlarged prostate. And they already said median sulcus palpable. So they're talking about benign prostatic enlargement. And you already inserted the catheter. Is there any role of doing a bladder scan if you already inserted the catheter? No. So there is no indication of doing a bladder scan anymore. Okay? So in such case, no need. The next step would be to check the PSA in this patient to know that how bad it is, to find out like if it is just a benign prostatic enlargement or should we also rule out prostate cancer. Very good question. So if anytime we insert catheter, our next step is to send the urine for microscopy. So they haven't given the microscopy option. If there was a microscopy option, then that would be our next step. In BPH, it will be symmetrically enlarged prostate with median sulcus palpable. It is possible to take PSA after DRE. There is no problem with doing a PSA after DRE. So even if there is a small slight increase of PSA after DRE, that will not be something that's like a dramatic change. So you'll not get, after DRE, it will not be like the significantly elevated just because you did a DRE. So maybe 0.1 or 2 has got increased, but that's not going to change your management. When we do biopsy and when PSA, so it depends. So biopsy is latter. So first is always PSA. And as we discussed, repeated PSA, if it's showing sign of or possibility of a cancer, then you do a biopsy, okay? So biopsy is not your first option. An old man with nocturia and long history of dribbling urine problems for 12 months with median sulcus palpable with enlarged smooth prostate. What is the next appropriate step? Same thing. So they're talking about LUTS in a patient for 12 months. And median sulcus palpable means they're talking about BPH. So this patient definitely will go for a PSA. Coming to this one, which is a very important question. 65-year-old man is having a checkup for prostate cancer. Last 2 years, PSA was 1.5 and now it is 3.8. So you see that even though 3.8 is not really high PSA, but it has jumped significantly in a year, in 2 years. That's why you did a biopsy and you found one foci of adenocarcinoma and Gleason is 4. So now you confirmed it is a cancer and this patient is 65. So the best option for this patient would be prostatectomy. A man presented with poor urinary stream and nocturia for 12 months. DRE shows prostate enlarged 6 centimeter, median sulcus palpable, dullness on palpation 2 finger above symphysis pubis, slightly elevated temp. What will you do next? Now, if we look over here, this patient has got a prostate enlarged and 6 centimeter enlargement, median sulcus palpable, but see this dullness on palpation 2 finger above symphysis. What does it mean? It means likelihood of a retention, right? So when there is a retention, you want to make sure if this patient needs a catheterization or not, and how much they are retaining. So they have an inserted catheter, so we can definitely do a bladder scan in here. Are you guys understanding like when we are choosing what? Because it all depends what has been done and then just do the next. Okay, so let's see. Try to concentrate because I know it is a confusing, but this is the best management you can get because prostate cancer, it is a really confusing, especially as part of Australian guideline. But the main thing is understanding that what will be the next step. So let's say that you have done a PSA for a patient for regular screening. The number one PSA was, let's say, 2. 2 years later, you did a repeat PSA. And that has increased up to 3. So even we say more than 0.7 increase, okay, in back-to-back PSA, that's the indication that something wrong is happening. So then rather than writing anything, guys, I want you to concentrate what I am talking at the moment because it is really difficult to like repeat these things multiple times, as you can understand. So I want you to concentrate rather than writing anything on the chat box for now. So you did a PSA 1, it came normal, let's say. Then 2 years later, you have found it it's more than 0.7 has got elevated. So from 2 to 3, that means that's more than 0.7, right? The next step would be that now that you are concerned, you would do a DRE. And DRE shows that there is irregular prostate has been enlarged. You did a MRI of the prostate. And MRI shows there is suspicious nodule. Then you do a transrectal ultrasonogram guided biopsy. The biopsy will give us the Gleason score, and if it is a cancer, and based on that, our treatment will be different. Could be active surveillance, could be radiation, could be prostatectomy, could be just a hormone therapy. The other aspect could be that sometimes with the prostate, they also include the retention. So if a patient who has got features of benign prostatic enlargement, which means they're talking about prostate enlarged, median sulcus palpable, that means they're talking about BPH. They also say that they say that there is dullness on palpation, or you can feel a mass above the pubic symphysis. That mass is the urinary bladder, and most likely they are talking about retention. So when there is a features of retention, next step is bladder scan. Bladder scan confirming retention, you can put a catheter, then send the urine for urine microscopy culture, okay, and then do a PSA. Now, someone who has got retention, they have already inserted catheter. That means there is no requirement of doing a bladder scan anymore. Okay. Someone who has got retention, you have done the catheterization. There is no option of MCAs in your question. So you go directly to PSA. Is this easy now, guys? Okay. So this one, a prostate cancer patient, has a Gleason score of 7, and you can see T3N0M0, features of metastasis to the lumbar bone. Now, there is not M0, that should be M1, right? So this is a metastatic prostate cancer. The options are orchidopexy, radical prostatectomy, and EBRT. Now, the best option should be hormone therapy. And I believe that is also in the exam. So if hormone therapy is in the option, you would choose that. If not, then the best other option would be EBRT. No, if it is just BPH, then there is no need of doing a urine analysis, because the only reason why we are doing a urine analysis, because retention patient can have the urinary infection. So no retention, no need of urinary MCS. In that case, you would go straight to the PSA. Like this one is the same question, but they have given androgen deprivation therapy in the option. So that was actually the question. No, at this time, prostatectomy is no longer the best option because it has already metastasized. Just the hormone treatment will be the treatment. Prostate surgery done for Gleason 7, post-surgery PSA 0.4, rises to 0.9. So you have already removed prostate and PSA has been rising. So after prostatectomy, we follow up the patient with PSA. And ideally, their PSA should not get high. Because it got high, patient had to go for a radiation. Now again, after 12 months, now it is 8.7. The question is, the patient doesn't have prostate. How come there is a PSA of 8.7? Which means there must be a metastasis. And the only way we can find out the metastasis is doing a full body PET scan. So in such case, you need to send the patient for PET. Have a look on this question. 65-year-old man diagnosed with prostate cancer, and the stage is T3N0M0 with invasion of the seminal vesicle. Sorry. So when seminal vesicle has been invaded, that's why it is T3. It is also called stage T3B. That means it is locally advanced, right? What's the best option for this patient? EBRT, prostatectomy, androgen deprivation, orchidectomy. Now remember, we talked about it that prostatectomy is not the best option when it is a locally advanced one. For such case, EBRT will be the best option. Okay, so when it is within prostate, prostatectomy. When it is out of prostate and not metastasized to the bone or somewhere, EBRT is the best option. So for locally advanced carcinoma, EBRT is the current treatment of choice. Have a look on this question. Old man with acute onset of pain in the lower back with some urinary symptom, significant weight loss, anal sphincter tone normal, On DRE, prostate is irregularly enlarged. Now that will give you a thinking that this is not BPH, it is prostate cancer. Dullness is there, so urinary retention is also there, slightly elevated TEM. What is your appropriate investigation that will lead you to diagnosis? Now, they're asking about the confirmatory investigation. The confirmatory investigation for something like this, so what do you think this patient has got? Looking at the question, this patient has got a prostate cancer causing the bladder outlet obstruction and also likelihood of a metastasis. Before you can diagnose metastasis, you need to diagnose the local cancer. So you need to first diagnose if it is a prostate cancer or not. So for prostate cancer diagnosis, you need to do a biopsy. So if they're asking what is the most appropriate investigation that will lead you to diagnosis, that will be transrectal ultrasonogram guided biopsy. Okay? Yeah, if next, that will be PSA. That's right. If it is metastatic prostate cancer, you need to know if it is bony metastasis. That means if it is locally advanced, then you can choose the radiation. When it goes to the bone or other organs, then hormone. Okay, so that's pretty much everything that we need for prostate. If you understand it, there will be no question in the exam, which is new, at least. Okay. You will be doing creatinine later on, Dr. Mitra. It's not the first thing that you would do. Yeah, so why would we do a transrectal ultrasound? It's very painful. So if you don't want to do a biopsy, you don't do a trans. Okay, before we finish today, just few other things I wanted to go through with you quickly. So renal mass. So one of you asked me last class about renal mass or incidental renal mass, right? So there is a RACGP guideline about incidentally detected small renal mass. So give this a rate. They have given a good idea. So many times incidentally, when you do an ultrasound, you can get a renal mass. That should be followed by a CT scan of the kidney because that will give us the best idea. Once CT gives us an idea that what is this renal mass? Is it a solid mass? Is it a complex cystic mass? And what is the Bosniak classification of it? So the Bosniak classification comes from 1 to 4, and chance of malignancy is higher for 3 and 4. So 3 and 4, there is a likely chance it is a cancer. But Bosniak 1 or 2, these are not cancer, these are benign and just can be followed up. Even they say that there is no need of any follow-up for this. So basically, we say that the treatment option for renal mass is active surveillance, so check with repeated ultrasound, or surgery. Now, when to do what, that's a little bit important thing. So anyone who has got a solid renal mass more than 4 centimeter has to be sent to the specialist for a biopsy. Okay, so these are the main things. So solid renal mass more than 4 centimeter, complex cystic renal mass with a Bosniak classification 2F, 3 or 4, more than 4 centimeter, or renal mass with evidence of metastatic disease. So just remember solid more than 4 because that's usually what will be given. Then you send the patient for biopsy. If biopsy will say if it is a cancer or not. If biopsy says that it is a stage 1 or T1 cancer, then ideally you can go for partial nephrectomy. Anything above T1 will go for radical nephrectomy. Okay? And less than 4 centimeter, you would mainly just follow this. So if it is Bosniak classification 1, nothing needs to be done. 2, nothing needs to be done. 2F needs to have follow-up, at least CT or MRI at 6 months and 12 months. Bosniak 3 and 4 will need to go for biopsy. Does it make sense, guys? So I'll just put it in here so that you can go through that. So I've just shared the link of this one. And you should also read, now that was the renal mass. What to do for incidentally detected adrenal mass. So that's important for exam. So I'm just giving this to your chat box also. So this is a RSCGP guideline, important for exam. So if you have got a patient, somehow you did a CT, found a adrenal mass, what's your next step? Next step is to find out that if the patient having any kind of hormonal disturbance. So you do a biochemical evaluation, you check for Cushing syndrome by dexamethasone suppression test, you check for metanephrine catecholamine to rule out pheochromocytoma, you check for aldosteronism. So you check all the hormone that has secreted from adrenal gland to see if it is biochemically active. If anything positive and patient symptomatic, will go for adrenalectomy. If it is asymptomatic, less than 40, still will go for adrenalectomy. More than 40, ideally you would do medical management if patient is unfit for surgery. So mainly if biochemically patient is positive, most of them will need a surgery. But biochemically, there is no problem. Then you look at the imaging characteristic. If the image or the CT shows the adenoma is less than 4 centimeter and it is benign, just follow up. But it is more than 4 centimeter or even less than 4 centimeter and suspicious for a cancer, that will also go for adrenalectomy. I know it is difficult for you to remember all of this now, but I want you to just open it sometime later on and then read it. Okay? But it is important. So that's basically all I would discuss today. Before we do neck lump. So everything is there. All you need to do is to do a little bit of work by yourself. If you think something is coming a lot, there is a guideline. And you need to just open the Google and search that in RSCGP. It is not very hard. So most of the answers are there if you are willing to read it. Okay? So rather than asking a lot of people, what do you think about it? First, try by yourself. First, go into the guideline, have a read. You will see that it is all written in here. And we are also discussing the same thing to you. So it's important to search, because with searching, you will find a lot of new knowledge, and that sometimes question will come from there. So let's say you have got a patient with neck lump. Always look for some of the red flags. So any lump that has been present for more than 2 weeks, recent voice change, that means hoarseness of voice, dysphagia or odynophagia, ipsilateral ear pain, ipsilateral epistaxis, unexplained weight loss. And someone who is above 40, smoker, alcoholic, previous history of head and neck cancer, family history, these are risk factors. So go through this initial thing, but always remember, if an adult patient comes to you with neck lump and there are risk factor there, your first line investigation should be a CT of the neck with contrast and a FNAC. These two investigations provide complementary information. So according to the new guidelines, CT is the first line investigation for all patients increased risk of malignancy. Okay? And they also say FNAC should be considered a first-line diagnostic test. So normally what I would say, before sending a patient for FNAC, it's ideal to do a CT. Okay, so CT first, then FNAC. If CT is not possible, then the alternative of CT will be ultrasound. What is more preferred than like between MRI and CT? CT is the preferred one for this case. And lots of other things can be done. So this is a very good discussion over here. So you can definitely go through it. Okay, you can see that obtain CT with FNAC. So they said do both CT. If CT suspicious, do a FNAC like that. Okay. Okay, let's talk about the submandibular. So you guys are not letting me to go today, right? That's the plan? So there is a good discussion about submandibular or salivary gland swelling. So let's follow that. So sometimes we follow diagnostic imaging pathway for salivary gland swelling. So if you look over there, so let's say you have got salivary gland swelling in a patient. The first thing is it a suspected inflammatory disease or is it a suspected solid mass? So if you suspect solid mass or a neoplasm, then MRI or CT will be done. And MRI CT, if it shows something is wrong, then FNAC. Okay. If you suspect something inflammatory going on, like sialadenitis, then you do an ultrasound. Now, if we come back to your question, it's an elderly patient. We would consider there is a possibility of cancer, right? So, and they're talking about FNAC, so we can definitely go for a MRI in this patient if CT is not there. Okay. All right, guys. So, Dr. Hassani, your exam is on 14th of August. Telegram, no, there is nothing. So as part of our first aid AMC, we only have a Telegram group. We don't have any WhatsApp group, but many times I see that even our candidates, they make separate WhatsApp group. So if I'm not sure if you guys also have one, do you guys have a separate WhatsApp group also, or you just do it by yourself? Yeah, so maybe like there are separate WhatsApp groups, Dr. Hassani, but we follow it mainly there is a Telegram group. Okay. All right. But if there is something like if someone is going for some specific months, like November, October is usually what you guys would go for. So not a bad idea to have a group who is just preparing for November, October. Okay. Do we need to find recalls from other group if we get enrolled for recall batch? No need, because we normally finish everything. Okay. All right, guys, I'll finish it here tonight. Thank you. Take care. Bye.